Hi, I'm Dr. Andrea Abbott, a surgical oncologist at MUSC Hollings Cancer Center. I'm thrilled to be here today with Dr. Whitney Graybill, who is board certified in OBGYN and board certified in gynecology oncology. We're going to be talking about cervical cancer, and January is Cervical Cancer Awareness Month. So first, let's lay out some facts about cervical cancer. South Carolina ranks 14th among all states for deaths from cervical cancer. That's definitely not something you want to be known for in the top 20, right? Especially when cervical cancer has fantastic survival rates, at least when it's caught early. But here in South Carolina, we're not catching these cases early. Is that what's going on?
Yeah, I think that's a big part of it. I think there's three different things. First is education. Educating the lay public about what cervical cancer is, what causes it, and how to best screen for it. The second are prevention strategies and screening strategies throughout the state. And the third is HPV vaccination. I think if we could improve those three things, we would see a big improvement.
So let's go back to the screening and talk about recommendations for that. It feels like in cancer care, maybe the screening recommendations are always changing and it's maybe hard to keep up with what that is. So tell me, what are the screening recommendations right now and what age groups?
Yes, that's a great question. It does seem like it's changing a lot. So the recommendation is to start screening at age 21 and to screen from ages 21 to 29 with a pap smear every 3 years. And when I say every 3 years, that's assuming that you have a normal pap smear, but some kind of cytology testing. And then from ages 29 we say up to age 65, and I'll go over that in a minute. There's really three different ways that you can screen. You can screen with a pap smear or a pap test every 3 years with HPV testing alone. And there are certain HPV tests that are FDA approved for just individual HPV testing. And then you can co-test, which is where you're doing both a pap smear and HPV testing. For HPV alone and co-testing with a pap smear and HPV testing, the recommendation is for every 5 years, assuming that you have a normal pap smear and a negative HPV. We recommend that you stop screening after age 65, again, assuming that you are not high risk and that you don't have a history of abnormal pap smears.
So I want to go back because I feel like that is a bit of a change. I thought that women were supposed to have pap smears done every year. So is that?
A lot of people think that.
Okay.
Yeah, so they've done a lot of studies and really they've shown that if you do a pap smear every year versus every 3 years for just pap testing alone, let's say, that you're increasing the number of pap smears and false negatives, but you're not increasing or improving outcome.
Okay.
Now that doesn't mean that you shouldn't have a pelvic exam. We still recommend it, and that's a really important distinction. We still recommend a yearly pelvic exam.
Okay.
Just to look at the vagina, look at the cervix, make sure we don't feel any masses on bimanual. But in terms of actually screening for cervical cancer with a pap smear, that is only necessary every 3 years. And the HPV testing adds so much because, again, if you remember that all this is driven by HPV, that when you're testing for the high-risk types and you're adding in pap smear testing, you can then space out safely every 5 years.
So does age 21, is that universal, or does it depend on when a woman becomes sexually active, or is it just 21 across the board?
That's a great question. And I'll start by saying under the age of 21, we don't recommend a pap smear regardless of when someone becomes sexually active.
Okay.
So let's say someone becomes sexually active at 16, we still don't recommend a pap smear then because there would be a lot of false positives. A lot of people contract HPV but then clear it, and it's not something to worry about. But we do recommend from ages 21 to 29 going ahead with the pap smear.
Okay. And so when a woman goes in starting at age 21, do they have to ask for the HPV testing specifically, or is that something that their physician will know?
So that's again where it gets a little bit tricky.
Okay.
So again, from 21 to 29, the main focus is on the pap smear. So that's where we're doing the every 3 year pap smear. We really add in the HPV testing at age 29.
Okay. So in the beginning, get your regular pap smear starting at age 29. And then are there any symptoms? Is there something that a woman should be looking out for that says, oh, you should definitely get HPV testing?
Well, if you think of, symptoms of cervical cancer, and it can occur in someone who's younger. The average age is 50 years old.
Okay.
But things that we think about are, abnormal bleeding. That can be from a multitude of different reasons, but particularly bleeding after intercourse is something that, we alert women to as kind of a big sign, as well as pelvic pain, abnormal vaginal discharge, and things of that nature that you would want to go into your GYN for
Great.
in general.
So now that we've kind of gone over when to get the screening, what does the screening do? So if they find cancerous cells or precancer cells, what comes next?
Yeah, so it really depends on what is found, on the HPV or pap smear test. If there's nothing that's visible that's of concern, but there's an abnormal pap smear, depending on what that is, we may bring someone back into the office and do a colposcopy. We put in a speculum and we actually look at the cervix with a microscope. It's a special type of microscope, but it allows us to magnify the cervix and see if there's any abnormalities. And then that leads, if we're going to do a biopsy, where we would biopsy. So in addition to doing a colposcopy and potential biopsies, if there is something that is visible on the cervix that is of concern, we may recommend that a patient undergo an excisional procedure, such as a cone in the operating room or a loop electrical procedure we do in the office, where we get a piece of tissue to look at more closely.
So I think probably people are listening and they're thinking, wow, this sounds really painful to be done in the office. So let's just try to break down some fear that might surround that. Is this a painful procedure? Do people have to take time off of work or?
They really don't. Patients do extraordinarily well. If we're doing a biopsy in clinic, there's very minimal discomfort that's associated with that and minimal bleeding. If we do more of an excisional biopsy, then that's something we usually do in the operating room as an outpatient procedure.
Okay. So you get the information you need from the biopsy, and that's when you would know if it was a cancer or precancer cells?
Right.
Okay.
So that's really going to guide the next steps. So if there is high-grade dysplasia, which is basically a high-grade precursor lesion, and that is the precursor that ultimately leads to cervical cancer, then that's something that we can excise in the operating room.
Okay.
If there is a cancer there, it depends on, the size of the lesion, depth of invasion, and then that would guide the next steps in terms of potential hysterectomy.
So I want to take this back for a minute to HPV. Are all cervical cancers caused by HPV, or how does that play into this?
We basically think that.
Okay.
HPV is present in 99.5% of cervical cancers. So it's very much an HPV-driven cancer. So that's why it's so important to do the screening and to identify the precursor lesions, because by treating the precancer, we can prevent the cancer.
So let's talk about that, preventing the cancer.
Yes.
I think that was number 3 on your bullet point for cervical education, vaccination, right? Okay, so let's just get that out there. Tell me about the vaccine. Who gets it? When do you start? What does it do?
Everyone should get the vaccine.
Okay.
No, so you can start at age 9.
Age 9.
Age 9.
All right.
We typically hear the recommendation for around age 11 or 12.
Okay.
But you can start as early as 9, and between the ages of 9 and 15, it's a 2-dose vaccine. So you get 1 dose of the vaccine, then you get the second dose 6 months later. And then after the age of 15, all the way up until age 47, you can receive the vaccine.
Wow.
Which is very different than what the previous recommendation was.
Okay.
It used to be 26, and pretty much anyone can get the vaccine up through age 26. And then we say after that up through 46, 47, it's really dependent on a conversation with your physician and whether they think that you would benefit from receiving the vaccine. But I offer it to all my patients within that age range. After the age of 15, it's a 3-dose vaccine. So you get the first dose. The second dose is 1 to 2 months later, and then the third dose is 6 months after the first dose.
And you said everyone should get it, but let's clarify that means girls and boys, men and women.
Yes.
Right? Okay.
Yes. Even though we're primarily talking about cervical cancer, there's a lot of HPV-driven cancers. Particularly, we see it in head and neck and other cancers, and men are affected as well.
Yeah, I think that's probably worth highlighting again. This vaccine is not targeted for cervical cancer. It's targeted for the human papillomavirus.
Correct.
Which causes anal rectal cancers and cervical cancer and head and neck cancer, right? So men and women. So how do you think, or do you have some suggestions for people who are listening that are like, oh my gosh, I can't imagine telling my 9-year-old they need to get this vaccine for what maybe is thought of to be a sexually transmitted disease? How do you broach that conversation with parents?
Yeah. And just because you can't get it at 9, I don't necessarily think everyone needs to have their child vaccinated for it at 9. But regardless of what age, whether it's 9, 12, 15, I think it's kind of the same conversation. I look at it very much like any of the other vaccines that we give children, and HPV, it causes sequelae. There are precancers, other benign conditions that are not associated with cancer, and then a number of cancers. And these are all preventative, right? So, here we see so many patients that come to us every day with invasive cancer. And, this is one of the times that we can prevent, I keep saying that, prevent it from happening.
Yeah.
And I see so many women, as a GYN oncologist, that tell me, especially with cervical cancer, gosh, I wish I would have had this vaccine, or I wish this vaccine would have been available, or I wish someone would have told me about it. And those same women are very proactive in vaccinating their children because they've been through it and they understand the ramifications. And so I don't broach it as a sexually transmitted disease. And again, I think the other really important thing is that anyone who's been sexually active has likely been exposed to HPV, even if they've only had one partner. So 80 to 90% of women, if they've had sex one time, have been exposed to HPV.
I think that is really important because we had talked before, about signs of cervical cancer, but there may not be signs that you carry the human papillomavirus, right?
No, not at all.
Yeah.
I mean, majority of people don't know it. And a lot of times we're exposed to it and we clear it and never knew that we had it. But there are certain strains of the HPV virus that the body doesn't clear so well, and it can become persistent. And those certain strains, if they become persistent, lead to precancer and cancer. So you a lot of times wouldn't know until you have that abnormal pap smear.
And then it's too late.
So,
yeah. Okay.
Well, as long as you catch it with the abnormal pap smear and it's early, then we can treat it.
Okay.
But if to even prevent that, get the vaccine, and if you want to worry about it.
And then we could stay out of the office that you treat patients in altogether, right?
Correct.
Yeah. Okay.
Correct.
So here at Hollings, I know that we try to do a lot of research, promote vaccines. So are there clinical trials or advancements in this area that you want to talk about today?
Yeah, I think, in the past 3 to 4 years, there have been a ton of advancements. One thing that we saw in clinical trials in the past few years is that in patients that have either persistent or advanced disease or even disease and can't have surgery that we would normally treat with chemotherapy, if we add something called bevacizumab, which works on blood vessels, as you know, a VEGF inhibitor, it improved overall survival in cervical cancer, which is, it's not very often that we see an overall survival improvement in GYN malignancy. So, and then other therapies like immunotherapy. Yeah. So there are immunotherapy drugs that we now add to chemotherapy, even sometimes in the upfront setting, that have improved progression-free survival and outcomes. We've also made a lot of advancements in targeted therapy for cervical cancer. So relatively recently, there was FDA approval for a targeted treatment for patients who have failed chemotherapy
Okay.
and have had recurrence. And that has shown great promise with a significantly improved response rate. So we're really excited about that as well.
It sounds like you've made tremendous improvement, starting with prevention, and then, for people who unfortunately maybe develop signs, getting some treatment in the office is a possibility, all the way to immunotherapy, which is probably better tolerated than some of the traditional chemotherapy. When the cancer is caught early, and I want to touch on fertility because the cervix is really important for carrying a pregnancy.
Right.
Are there some fertility-sparing options that are available to women?
Yeah, definitely. So for women, when it's caught very early, and it's a very small lesion, sometimes we can just do that excisional procedure, like I talked about, that cone excision where we just take a piece of the cervix, and then we can just monitor them closely until they're done with having children. For patients that have a visible lesion, so where we used to say you have to have your uterus and your cervix taken out, as long as it's less than 2 centimeters and meets certain criteria, then one option would be to do something called a trachelectomy, which is where...
What is that?
I know, it sounds scary.
It does.
But it's actually where we take the cervix and the tissue out to the side of the cervix. Radical trachelectomy is what it's called. And then we attach the uterus to the vagina. And we put a stitch around the base of the uterus that would keep a pregnancy inside because you don't have the cervix there to perform that function. So it's a big procedure, and it's for a very specific group of patients that, again, meet certain criteria with age and, the cervical cancer they have. But it's definitely an option. I've done it for several patients, and there have been several pregnancies. So that's exciting.
That is. If you don't have the ability to catch something early, at least you know that there's still options for you. Definitely. It does sound very complex. So do you think that women should be seen, at a center such as this? Is this something that happens in the community? How do women know to select the right physician if they're diagnosed with cervical cancer?
No, I definitely think if you have a cervical cancer diagnosis, you should be seen by a GYN oncologist. I think that's key. I think being at a center where they see a fair amount of cervical cancer and are comfortable treating it is really important. Here, unfortunately, like we discussed, we see a fair amount of cervical cancer. So it's something that we unfortunately deal with pretty regularly. But again, we understand how to take care of it, and we can give patients, all their different options. And if they need things like clinical trials or new up-and-coming treatments and targeted therapies, we have that to offer them.
So as we close today, is there anything else that would be important for people to know for cervical cancer or even ovarian or uterine cancer? Because I know you treat more than cervical cancer here.
Yeah, no problem. I'd say for cervical cancer, the biggest message is, educate yourself, your family, get regular exams, follow the screening guidelines. Your OBGYN should know what those are. And there's also multiple websites where you can look those up and get vaccinated for sure. In terms of uterine ovarian cancer, I think, again, education is key, and to know what to look for. It's important to, kind of take ownership of your body, know what's normal for you and what's not, and what can be concerning. Uterine cancer, I tell my patients, postmenopausal bleeding is the number one sign. Mm-hmm. So if you've gone through menopause and you start having your period again, that is not normal. You should go see somebody.
Okay. Is it always cancer? Or talk to me about uterine fibroids, because that can be common also, right?
Right. It's not always cancer.
Okay.
By any means. But again, any kind of bleeding after you've gone through menopause isn't normal. And you want to rule out uterine cancer. There can be things like polyps in the uterus and other things, like we talked about fibroids. Polyps is probably one of the more common things. But again, the one thing we have to make sure of is that it's not uterine cancer. So you definitely just want to get it checked out.
Okay.
And in addition to that, if someone has a significant weight loss that's unexplained, a significant change in bowel or bladder habits, so all of a sudden you're really constipated or you're having a lot of diarrhea and that's not normal for you and it persists, that's something you should get looked into. And then, unexplained abdominal and pelvic pain that's persistent. Ovarian cancer has kind of been dubbed the silent killer, but if you really look at women who've been diagnosed with ovarian cancer, usually they've been sent to a GI first.
Right.
And they present with this, history of several weeks or months of bloating, abdominal fullness, decreased appetite, weight loss, fatigue, and a change in bowel habits, and get diagnosed with, IBS or something like that. And lo and behold, end up with advanced ovarian cancer. So, and again, not that all those symptoms are ovarian cancer, but if you're a female and you experience those symptoms, you should at least get checked out and potentially get a vaginal ultrasound.
In talking about ovarian cancer and screening and getting checked out, I've read about the CA-125 blood test. Is that reliable to detect ovarian cancer as a screening measure?
Yeah, that's a great question. Unfortunately, we don't have any good screening tests for ovarian cancer. There have been so many studies that have been done looking at that. Even if you combine a CA-125 blood test and regular ultrasounds to look at the ovaries, it still isn't a great screening method. CA-125 is great at following ovarian cancer if someone's been diagnosed, or giving you an idea if someone has it if they have more advanced disease. But in terms of early detection, it doesn't do a great job. And so we really don't recommend that women ask their physician for just routine CA-125 tests.
I feel like I would be remiss as a breast cancer surgeon to not mention BRCA testing as we touch on ovarian cancer. Yeah. So just maybe highlight quickly who should have genetic testing and ovarian cancer, maybe screening if based on their family history.
Yeah, no, that's a great question as well. And I get a lot of referrals for that. So, basically anyone who has a diagnosis of ovarian cancer, we automatically send to genetic testing for BRCA testing, or to genetics for BRCA testing. And that's changed since I've been out in practice. We used to do it based on risk factors, but now if you've been diagnosed with ovarian cancer, you automatically get tested. And then we also look at family history. So if someone has a significant family history of breast and ovarian cancer, and we look at things like early age of onset, some of the family early age of onset of ovarian cancer and early age onset breast cancer. Really, we recommend that the person with the cancer gets tested, and then if they're positive, then the family member gets tested.
When a woman is diagnosed with cervical cancer, how should she pick her physician? I know that you are double board certified. You're boarded in GYN and also in gynecology, oncology. Is that what every woman should look for their treating physician?
For someone with a diagnosis of cervical cancer, I would say yes. I think it's important that they see a GYN oncologist, just because we have the expertise in treating cervical cancer and know all the different options that we can offer women, whether it's an early stage and they might just need an excisional procedure, or as we talked about, the option for fertility-sparing that a regular OBGYN wouldn't be able to offer or perform, all the way to the clinical trials we're talking about.
Great, thank you. And thank you for tuning in for Hollings Cross Talk. This is where we connect with the community to share news that is changing what is possible. If this is your first time watching, please go to our multimedia page to watch past episodes and check out the Hollings news page for our latest updates.